So this is presented by myself, Paul Selby. I'm a consultant pharmacist, and my colleague Aris Saoulidis, who's a senior pharmacy lead, and we're in a job share arrangement at the East GMSA. And we're here primarily to look at the application of the commissioned pharmacogenomic testing for the mitochondrial variation associated with aminoglycoside-induced hearing loss. As pharmacists, we absolutely have come through this through a sort of medicines lens, and working from the GMSA, we're very much interested in exploring and discussing and explaining some of the issues around implementation rather than looking in depth at the science that underlies the testing. So we're welcome to take questions on any of those specific topics if we feel we can manage them via the Q&A, and you'll see when we get the agenda up, we've got plenty of chance for that. So Aris is going to lead the first session, and you can just see that we're there, so you know who you're expecting to see. And as I mentioned before, the webinar has been set out to what we think are the needs based on discussions that we've had and feedback that we've had. So we're splitting this up into 3 sections: a background to the test, and then current testing applications and future testing applications. We've got a good couple of sessions and plenty of opportunity to have a question and answer. That's intentional to try and split the session up, make it as interactive as possible, but also to make sure that we're covering as much content as is relevant for you as participants. So it gives me great privilege to introduce Aris Saoulidis, who's going to start by telling us a little bit about aminoglycoside-induced hearing loss, and in particular the background to the test. Aris, if you just tell me when you want the slides moved on, I'll do that for you.
Thank you, Paul. Hello, everyone. My name is Aris. Thank you for the introduction, Paul. Yes, I'll be giving you a bit of a background on the molecular biology of the test and some of the medication safety aspects of the test, as well as the epidemiology and the genetics of it and how it impacts our patients. Paul, would you like to move on? So aminoglycosides are a very common class of antibiotics that we give routinely to patients with infections, and they're used widely across the world in many clinical situations and across many different patient pathways. Specifically, aminoglycosides include gentamicin, tobramycin, and amikacin, and in some cases the local agents like neomycin. But the key thing here is that they affect many different patient pathways, and patients from different clinical areas could be exposed to these antibiotics at some point in their lifetime. Another key issue with those antibiotics is that they have a very narrow toxicity and efficacy window. So if you give just a little bit too much, you can actually start to have toxicity effects on your patient. If you give too little, it doesn't work as well. So in clinical practice, you have to be very careful with giving just the right amount of drug in those patients. And there's implications there. For example, if your patient has other factors that can make this calculation a bit more complicated, such as kidney problems, because some of these medicines are removed by the kidney. And in practice, we see patients who have aminoglycoside antibiotics, they often suffer from ototoxicity. And this can include sensorineural hearing loss, which is sometimes cochlear ototoxicity, or vestibular ototoxicity. So it can also cause problems with the balance as well. And in the long term, this can present as, for example, actual hearing loss, tinnitus, and even deafness in some cases. So some patients will be more genetically predisposed to this hearing loss and ototoxicity, and this can happen even after a single dose, or in some cases after the accumulation of doses, of many doses in a lifetime. So generally speaking, I think that patients who don't have the genetic predisposition to this ototoxicity will suffer from it after having many doses that have reached high toxicity levels and accumulate in the mitochondria, that, as we will see in a minute. But essentially here we're exploring more about how genetic predisposition can be predicted in those patients and how we can manage that clinically. Next slide, please. So there was an MHRA alert, the Medicines, Health and Drugs Regulation Authority in the UK, in 2021 published essentially a reminder alert to clinicians that there is evidence that patients with a specific genetic variation in a mitochondrial gene can actually predispose to an increased risk of deafness after being exposed to these drugs. This genetic mutation is prevalent in about 1 in 500 patients of the UK population, and in some patients with specific ethnicity and genetic ancestries, that prevalence can be a little bit different. So, for example, in some specific subpopulations of Chinese origins, the prevalence can be as high as 1 in 3. But for the average UK demographics, the prevalence is about 1 in 500, so that's 0.2%. And there was an MHRA alert essentially to remind clinicians that this is a real issue that affects many patients because of how common these medicines are, and essentially to remind that genetic testing is available, but it should not delay any urgent treatment for patients who present in A&E, for example. So there are some patients that you can predict that they might have this because if their mother had deafness, for example, and that's because of the mode of inheritance of this genetic variant. Next slide, please. So the key recommendations of the MHRA alert was that we should have local guidelines that clinicians can follow on how mitochondrial mutation screening could be done in those patients with a maternal history of deafness, for example, or those who have actual mutations in the mitochondria, and those who might require aminoglycoside therapy in the future. So if your patient belongs in a clinical area like cystic fibrosis, which means that they might be predisposed to having more infections in the future, that will require aminoglycoside treatment, it might be appropriate to actually prioritize these patients for genetic screening preemptively, to do a preemptive pharmacogenomic test, so that when the time comes to give them antibiotics, you can optimize this based on the genetic risk for ototoxicity. There's many areas, clinical areas that such patients can be identified, such as those patients with bronchiectasis or urinary problems, or other patients who are immunocompromised, for example. Next slide, please. And just a touch on the genetics. I think many people on the call are geneticists already, so correct me if I'm wrong with anything. So in this case, a lot of the evidence revolves around a specific gene called the mitochondrial RNR1 gene. This codes for the 12S ribosomal unit in mitochondria. And the mitochondrial DNA has about 37 genes, and it's only inherited via the mother. There's a tiny amount of mitochondria that's inherited by the fathers, but most of it comes from the female egg, essentially. Usually, when you inherit mitochondria, there is something called the mitochondrial heteroplasmy, which means that in some cases, there is almost different mitochondrial mutations inherited and transferred throughout the body. But in the case of this specific genetic mutation, the evidence shows that most patients who have this mutation in all of the mitochondria in the body. So there are mitochondria in all of our cells in our body, and as you know, they are the powerhouse of the cell. And if something goes wrong with those mitochondria, that means that cells might inevitably die. If you go back one slide, please. So The most evidence-based gene for aminoglycoside-induced hearing loss relates to mitochondrial RNR1 gene, and just to tell you what those codes mean is that in the blue box, the mTRNR1 is the name of the gene. M signifies that it's a mitochondrial gene. The number is the position in the code of the DNA of the mitochondrial genes. The DNA, the plasmid, which is a circular molecule, and the A to G reference means that the normal base pair for the DNA nucleotide is usually an A, adenosine, and in this case is mutated to the G, which is guanine. And when it's substituted to the different nucleotide base, sometimes this can create problems down the line. So if you go to the next slide, please. So in this case, this particular mutation makes the ribosome that's produced by the mitochondria to look like a bacterial ribosome. So because we're giving antibiotics to these patients, those specific antibiotics can bind to the mode of action is that they bind to bacterial ribosomes, which produce proteins for the bacterial cells. And they bind permanently to those ribosomes. That means they're very good antibiotics and they kill those bacteria really well. But because of the mutation in our mitochondria here, the antibiotic is also able to bind to the human ribosome because it's from a chemical point of view, it has more affinity for it now. So that means that any antibiotics we give to the aminoglycoside antibiotics that we give to those patients will be essentially toxic for mitochondria at even normal therapeutic levels. So even if you don't give them by accident too much, if you don't reach toxicity levels in those patients, normal drug levels will cause toxicity for these patients. And in some cases, this can cause permanent hearing loss or ototoxicity after even one dose. In some cases, it can happen after some accumulation has taken place, after multiple doses, for example. Next slide, please. So in summary, we have a drug class of antibiotics called aminoglycosides, which are used clinically across many different patient pathways. There are many different clinical areas that need to access these antibiotics, and the classical toxicity effect is hearing loss and ototoxicity, but this can change depending on the patient's exposure to these antibiotics or the genetic susceptibility. In this case, we're concerned specifically with the one gene, mTRNR1. There are more genes that can affect this, but they're not currently available in the NHS. And the evidence is limited for clinical use. The ototoxicity, the molecular cause of this is because the mutated ribosome looks like a bacterial ribosome, which the antibiotics target. And there was an MHRA National Safety Alert issued 3 years ago relating to reminding people of the risk and how to manage this risk. And testing is available through the NHS Genomic Medicine Service and the genomic laboratory hubs, and Paul will talk to us about this.
Thank you very much, Aris. That's really helpful in terms of just setting the scene. And as you say, we're going to talk a little bit more about testing, what's commissioned, and certainly hopefully try to deal with some of those issues that have been raised and lots of the questions around the different types of testing and the different patient cohorts that would be available. So I'm very much going to look at current and future testing applications. And in particular, we've got two areas where this is of real interest. One is in sort of routine testing, which is done through the laboratory, the Genomic Laboratory Hub, and one which is there's a lot of interest in point of care testing, in particular for neonates. So those will be the areas I'll cover. And again, similar to Aris' presentation, there'll be a range of information, which for some people will be repetition and for some people will be new. So firstly, we talk about the National Genomic Test Directory. So this is essentially a directory of the commissioned genomic tests that's available on the NHS, funded by NHS England. And if you're interested, you can go to the website at the bottom, but essentially at the moment it's got two documented testing directories, the rare and inherited disease directory and the cancer test directory. So we'll be referring to the rare and inherited disease test directory when we're talking about the test directory in this case. And as you'll see later, point of care testing isn't explicitly covered by this test directory. In terms of where the laboratory sits, so you can see we've got the 7 individually coloured areas of the country, and there are links between the genomic laboratory hub, so that's a physical laboratory or set of physical laboratories serving the population of an area, and they're linked to the Genomic Medicine Service Alliances, which are focused on delivery and implementation and education of patients and staff in the region. There are a range of testing techniques that could be used at the Genomic Laboratory Hub, depending on what is being tested for, what the indication is. And if you were to look at something like the Rare and Inherited Test Directory, there are a whole range of different tests depending on what we're looking for, both in terms of the condition and in terms of how that would be applied to clinical practice. What's important for when we're looking at variation in the MTR and R1 gene is that the testing is targeted, which is essentially looking for one specific variation at the moment, and in the future for multiple specific variants, so single nucleotide polymorphisms generally. So I'm going to start by talking about the laboratory testing, where it appears in the test directory and how we're already using it. This is a copy of the monograph which exists for a particular test which is denoted R65. And this is one of the tests looking at aminoglycoside exposure, posing risk to hearing, and in particular to identify the M155580G variation. And you can see there's 2 areas here of importance in particular. One is the testing criteria at the top. And these are essentially the patients who NHS England supports testing for at the moment, and these can change quite quickly. And so you've got these 2 areas. So one is individuals who have hearing loss, who've been exposed to aminoglycosides. And the other one is one that's slightly more complicated in terms of the implementation, which is patients who have a predisposition to gram-negative infections. And Aris commented on this already, and in particular used examples of patients with cystic fibrosis. You can see at the bottom the associated tests. That just sets out the kind of testing that's done, and we can see quite clearly here that it's looking for a single targeted variation, I should say. I do apologise if I say mutation rather than variation. We're working very hard to shift the language to variation. In terms of how that testing would look at the East Genomic Lab, so R65 is considered a core test. It's available to all genomic laboratory hubs. It would be available to clinicians provided your patient satisfies the criteria set out in the test directory. And an example that has already been given is cystic fibrosis patients who are tested at some but all national centres, and certainly would be a cohort that we would know have a high chance of having an aminoglycoside at some point in their treatment course, but certainly would be eligible in line with the criteria. The turnaround time, so this is the time taken to turn around the test in the laboratory. The recommendation and the target is 42 days. It's classed as a sort of retrospective diagnostic test in that scenario, and therefore would be particularly if you're looking for the patients who've already developed the hearing loss, that would be the case. Tests can be processed urgently, would just require checking with the lab about turning that round, and typically urgently would be looking at within 14 days. So one of the issues that we would have as clinicians and pharmacists is about getting the information at the point we need it. And one of the difficulties with waiting 14 to 42 days to get a result back in order to action that, includes the timing to start antibiotics. And one of the ways that we can overcome that, one of the technologies that's being developed, is something called point of care testing. And you'll either be familiar with point of care testing more broadly. Well, this is where we're testing patients much closer to the bedside, or potentially at home, and making things a single test there and there at that point in time, essentially. It's got numerous applications outside of genomics, and has been incredibly successful in the field of infectious diseases in particular. So I mentioned here about the time to antibiotic administration, and obviously if we're looking at things like sepsis, the expectation is that you would deliver the first dose of antibiotics within the first hour. And so if you have a test that then needs to be completed, reported, and published, we would expect to take longer than that time. So the laboratory testing that we discussed is really, really valuable if you can identify a cohort who may need aminoglycosides in the future. Because we have the time to turn it around, it's a very good way of getting the testing. It's very robust, very cost effective, but it does require the time to be able to process that. Point of care testing sits slightly different and can get you a quick time to result, but it's often limited in terms of the targeting. And as we saw earlier, we're only looking at 1 to 3 variations at the moment, and so therefore this topic, testing, actually reflects quite a good opportunity to do this. But I would say that there is no routine point of care testing in practice relating to genomics at the moment. One of the large areas that's really caught the imagination, and with good reason, in this field is the testing in neonates. So I know we had some pediatric and neonatal intensive care staff on the call, and some pharmacists. I'm sure you'll have heard of this, and in particular the approach that was taken for a study called PALO. But this is really looking at a population of in neonates. So we use gentamicin in particular for the treatment of neonatal sepsis. As I mentioned before, it's really important that we give those antibiotics on time, and therefore the introduction of a point of care test to identify patients who we would try to avoid aminoglycosides in to reduce the hearing loss, and in particular trying to avoid those cases where even a few doses at an early stage in life can have lasting, lifelong implications. I'm going to talk a little bit more about this study and just set out some of the details, but it's a really good example where they were able to deliver testing without disrupting normal practice, and has generated a lot of excitement. So you can see here, it was a reasonably large study. It was only in a couple of neonatal ICUs. But they were at the sort of most complex ends of those ICUs. It was recruited in the Northwest, and had a significant number of neonates who were recruited. You can see there in terms of the standard antibiotic regime, so both sites use gentamicin within their first line therapies, and so there's real value in providing this. And the test was completed using a buccal swab, so that's getting a swab collecting cells from within the mouth, and then that was performed on what's called this rapid genotyping platform. In a preclinical assay validation, this was able to be run in 26 minutes, which is widely reported. We'll see in future slides how this was done, so that when looking at the dose to first antibiotic, it was actually made no difference in that. You can see on the right hand side the broad route that we would take, so we can get the antibiotic prescriptions given within that time, and patients who had a positive test were confirmed by something called Sanger sequencing, which, if you're familiar with it, would be our gold standard confirmatory test. The other point I would like to make is that within this study, neonates with the variant were referred for family counselling to clinical genetics. And so obviously when we think about things like implementation, we always have to consider how we deal with the aspect that the information would have on the family and how we treat the other members of the family who might be affected. The primary outcome of the PALO study was to look at the number of neonates successfully tested. And you can see here, so overall 424 out of 526 infants were successfully tested. And you can see a bit of a breakdown on the right-hand side, predominantly recruited from one centre. And there were some issues early on in the trial, which have been anecdotally reported, which led to the sort of the relatively high failure of the system. And in particular, some of those were related to the environment that the machine was left in, allowing exposure to light and therefore causing the tests not to report. So that was addressed within the study, and as you can see from the numbers, actually there was reasonable success throughout. There were a number of patients who were not tested, and the reason for this is not recorded. So after they'd been consented. Some of the secondary outcomes are also very interested. So they were looking at how many participants were identified, and that was 3 participants in the study out of those samples. There was this 20% of neonates where the testing was not undertaken. We saw that on the previous slide, which was quite high, but there were some reasons for that. One of the things that they did in this trial protocol is that the time to swab was very good. So when they were doing swabs for MRSA, as would be standard during admission to the neonatal ICU, they would also take the swab for the MTRNR1 test. And you can see here that the time to antibiotic administration in the study was 55 minutes, which was against a control of 55 minutes, looking at previous data in the immediate time prior to intervention. So it clearly shows that a point of care test has value in providing the test result within a time which doesn't prevent antibiotic administration being delayed. I've seen widely reported very high sensitivity and specificity, but actually there were a few false positive results within the study, so still very high sensitivity and specificity, but something I think we should be wary of, and justifies the repeat testing for those who have positive results. Now, one of the things we'd be particularly interested in is how this has been adopted, and certainly the questions that I've had from colleagues has been around how do we bring this in, how can this be done? There is ongoing development of the evidence base through NICE, and that's one of the areas I'm going to touch on in the next section. But essentially, where this has occurred, it's been through local clinician, individual centre driven adoption. And as you can see, the 2 examples that we've got are Manchester and Brighton, and in Manchester as the sort of primary trial site of the study. They've sort of just taken the decision to continue that on. There's currently no adoption in the East GMSA region, and that really reflects the difficulty in terms of funding the test and the kits and rolling out implementations, and the difficulty that the NHS is having more widely. Currently, I haven't seen any adoption for other indications, so there would be a justification potentially for looking at doing testing for any patient on an ICU, any patient who's under an infectious diseases team prior to starting this, but that hasn't been considered and would need to be considered separately and isn't covered by the NICE work. So I mentioned that NICE have what's called an early value assessment going forwards. And this is in particular focusing on babies, so the patients at the neonatal ICU setting. Some of its findings are that the kit can be used while further evidence is generated. And some people had interpreted this as the gene drive kit can be used, but actually it's really about establishing a better evidence base before a decision is made on that. We saw from the trial that any positive results should be confirmed by a laboratory, and it also recommends around healthcare professionals thinking about the possible implications of positive test results and ensuring that we've got links either with clinical genetic services or that we've got the ability to provide that. A few more of the recommendations which will drive how this is delivered in the future is around gaining further evidence, and there'll be a bit of an ask for me at the end of this presentation. But the areas that the NICE EVA wants to look in particular about how the test affects time to antibiotics, how it affects antibiotic prescribing decisions and the technical performance of the test. And there is an evidence generation plan which you may wish to have a look at, and in particular that focuses on delivering the care in the neonatal ICU setting. It's got the data that would need to be collected, so that basically sets out a standard data set to support getting the evidence that would be needed to move that on, and that there is support from the manufacturers of the testing equipment, and also gives some validation to the concept of presumed consent. So in this setting, based on the study and the way that it went through ethics and support through NIHR, they worked on presumed consent for this, and that's been a principle that has been sort of suggested to be upheld. So I think that's again quite reassuring when we're thinking about implementation and how we can use this. One of the other areas that's changed, or that we're expecting to change in the future, is following submission to the National Genomic Test Directory to test an additional 2 variants within the MTRNR1 gene. And in particular, these are 2 variants which are have reasonable evidence, certainly strong evidence, but the variants are slightly less frequent, so they're even rarer, and therefore the evidence base is limited by that. But they are certainly suggested by CPIC, so that's the Clinical Pharmacogenomics Implementation Consortium, who are a multinational group of academics, to be at increased risk of aminoglycoside-induced hearing loss. So you can see the 3 listed variants there, the M1555 A to G variant, which we already are testing for, and then those 2 additional variants that are likely to be brought in. Again, the testing method is to be confirmed, but is likely to be single nucleotide variants only. We'd be looking for 3 variants rather than just the single variant at the moment. And one of the changes that this will potentially lead to is, while the testing is updated, the reporting may also be updated. And I've just wanted to take a couple of screenshots essentially from the CPIC guidance, because I thought it was helpful just to think about some of the wording that's going to be used. So what we're really looking for here are variants that are at increased risk of aminoglycoside-induced hearing loss. And you can see that quite clearly here. And in that phenotype, we would therefore be looking at some therapeutic recommendations would be to avoid aminoglycoside use unless the high risk of permanent hearing loss is outweighed by the severity of the infection. So one of the caveats to all of this testing is that if you have limited antibiotic choices and you feel that an aminoglycoside is needed, then you can weigh up the risk and the benefit of providing that. And so our reports are likely to look at patients who are at increased risk or at normal risk of aminoglycoside-induced hearing loss, with a recommendation in line with that previous slide. For those of you who may look at the CPIC guidelines, we expect that patients who have an indeterminate risk would be classed as having normal risk for the purposes of reporting against the genotype and the outcome of that. So where does that lead us forward? Where's my ask? What are the next steps? So we, as I've said before, we've had requests and consideration to increase testing. Absolutely, we are guided by clinician need, and the way that the test directory works in this, in the way that's commissioned by NHS England, is that it's guided by clinicians, patients if they so wish, but that the clinical services are driving the test requests and the test uptake. However, if you have an interest in introducing this testing for your patients, please do get hold of myself. It's really important that we plan the GLH for testing numbers and to make sure that this is delivered in the time frame that it's needed and in a way that is helpful to the service. The other area where we discussed is the point of care test and the evidence generation by NICE. So supposedly they're looking at a 3-year implementation period, so that's up until about 2026. And certainly one of the really important things is if there's interest in bringing in a point of care test, that we gain information on that, that we establish to commit to increasing that evidence base so that we can benefit the services more widely. One of the things that I've just mentioned that I realise I haven't commented on for the point of care test is that my understanding is that the manufacturer of the MTR and R1 point of care testing platform is looking at incorporating those additional variants as well as the M1555AG variant as well. We did a national piece of work just to try and help those clinicians who might have some interest in increasing testing, and we had a task and finish group which is primarily consisted of a range of pharmacists and a couple of GLH labs and representatives from NHS England. And certainly we came up with some recommendations about some of the patients that might benefit from this, in particular considering things like whether patients have already got existing hearing loss or family history of hearing loss, or whether they are have been exposed to aminoglycosides before. So I'll get a clearer version of this circulated, but that's felt to be helpful. And finally, I just so I've got 2 slides left. The penultimate one, I wanted to share some additional resources. So for clinicians, Genotes has a page on patients requiring aminoglycoside antibiotics, which has got an example and it's quite clearly set out and very nice to look through that case. For anyone who's interested in implementing pharmacogenomics testing, and in particular how we would introduce the laboratory-based testing, there is information on this specialist pharmacy services website on some of the things to consider there. And again, you can contact a GMSA pharmacist to get in support with that. If you're interested in hearing loss, you may be interested in the East Pediatric Genomics Forum webinar, which was excellent on hearing loss. And if you're looking for patient information leaflet, there is a testing fact sheet with the Cystic Fibrosis Trust on this issue. If I appreciate that there are a number of people who are not from the East GMSA on this call, so I've included this slide for contact for who to get hold of in the various regions of the UK. The map is the same one as we were shown before, and these are all the consultant pharmacist or pharmacy clinical leads. I'm going to call the session to an end there, and just as I said, thank you very much for joining, and hopefully we'll see you in future Genomics BITE learning sessions.